Good morning. This is Dr. Rajalakshmi, and now I'm going to talk about how to interpret how to interpret various renal functional tests. So every physician and every ICU doctor, we do renal functional test almost on every day on every patient to monitor the response to our treatment and to monitor to diagnose various kidney related problems and to decide upon the short and long term prognosis. What are the basic functions of the kidney? Excretory, homeostatic, and synthetic functions. Excretory function means it excretes all the waste products from the blood, like blood urea and creatinine. Homeostasis, it maintains normal homeostasis of fluid or water and electrolytes. Thereby, it maintains normal acid-base balance within the circulation. So any disturbance in the kidney function can alter the volume status, can alter the concentration of the electrolytes, thereby can alter acid-base status. It can push the patient into acidotic or alkalotic side. Synthetic functions means it secretes renin and 125 dihydroxycholecalciferol. The later one helps to maintain calcium homeostasis and maintains normal bone health. Renin is the most important hormone for cardiovascular physiology. It maintains normal intravascular volume and it plays a vital role in maintenance of vascular resistance. So any subtle change in the renin level can push the patient into hypertensive or hypotensive side. Excessive secretion of the renin can cause refractory hypertension and hypernatremia. This hormone is gaining popularity recently in the area of critical care, and extensive investigation is going on to prove its efficacy in the management of septic shock. Why do we need renal functional test? To diagnose various kidney related problems and to monitor the response to treatment and to monitor the side effects of our treatment. Many antibiotics or many therapeutic modalities that we use in our day-to-day practice can push the borderline kidney function and can cause kidney dysfunction, especially when there is a borderline kidney dysfunction. And to estimate the short and long term prognosis of a patient and to decide upon the need of RRT and long term care. GFR, glomerular filtration rate, is one of the most important tests to estimate the function or to assess the function of glomerulus. What is GFR? It is the rate of clearance of substances from the plasma. How to assess GFR? We can depend upon exogenous markers or endogenous markers. But the exogenous markers have to meet the following criteria before they enter into the practice. They should not have any extrarenal elimination. There should not be any tubular absorption or secretion. And they have to be secreted into the plasma at a constant rate. And they have to get filtered freely at the level of glomerulus. The exogenous markers like inulin, EDTA labeled, chromium labeled with EDTA, 99 technetium labeled DTPA, and iohexol. But all these exogenous markers will require special setup and team of experts. So to simplify, we can use a serum creatinine or creatinine clearance. Creatinine clearance is urinary concentration of the creatinine into urinary flow rate divided by the plasma concentration of the creatinine. But the problem with creatinine is it has been associated with many limitations. It can be secreted from the tubules, can cause false high level of the creatinine clearance. Delayed rise means after cessation of 50% of the kidney function, then creatinine starts to rise. So if we check serum creatinine or creatinine clearance in the earlier stage of kidney dysfunction, we may not pick up and we will miss the kidney dysfunction. Confounding factors: if patient is severely dehydrated or hypovolemic, if patient consumed a lot of protein rich diet, or he had excessive, if he has done excessive exercise before the day of test, it can cause false elevation of the serum creatinine. Pregnancy, there will be augmented renal clearance as a physiological change in the pregnancy. So the baseline creatinine itself is low. So what is the threshold to call it as AKI or to call it as increased or decreased creatinine clearance? These are the areas which are enigmatic in case of the pregnancy. So we can stage CKD depends upon the GFR. Stage 1 more than 90, stage 2 60 to 89, 3A 40 to 59, 3B 30 to 44, 4 50 to 15 to 29, less than 15 is end stage renal disease or stage 5. The second or third test is blood urea nitrogen. Blood urea nitrogen is end product of protein metabolism and urea cycle in the liver. It's basically produced in the liver, but only 85% of the urea is excreted through the kidney, and remaining 15% will get excreted through the gut. So the urea can be elevated in the problems other than kidney dysfunctions. For example, upper GI bleed, dehydration, excessive protein diet, and catabolic state. These are the scenarios where we can see high urea without kidney dysfunction. If there is decreased production of the urea, even if there is kidney dysfunction, the urea will not be elevated, like liver failure, starvation, and low protein diet. Another parameter is urinary creatinine ratio. If urea creatinine ratio is it's urea creatinine ratio. If urea creatinine ratio is more than 20, means the cause of AKI is pre-renal. Such patients can benefit from the IV fluid resuscitation or free water deficient. Some patients will be having increased urea and hypernatremia. So in such scenario, by estimating free water deficit and by replacing the free water, we can avoid kidney injury. If urea creatinine ratio is 10, the cause of AKI can be intrinsic. If in case of GI bleed, urea creatinine ratio will be more than 30. Because of all these limitations, urea is inferior to creatinine in the estimation of acute kidney injury. Proteinuria. The normal protein level in the urine is less than 150 milligrams per day. In that 150 milligrams, 30% is albumin, 30% is globulin, 40% will be tam horsefall protein. These are the normal proportions of various proteins in the urine on daily basis. Proteinuria we can see in case of nephritic or nephrotic syndromes associated with glomerulus and tubular disorders like interstitial nephritis. Increased production of proteins like multiple myeloma and benzosomes proteinuria. UTI and urinary tract tumors can cause increased protein levels in the urine. The false detection of the protein we can see in case of the rhabdomyolysis, where myoglobin can be detected as a protein, and hemoglobinuria, where hemoglobin or globin can be detected as protein. So before interpreting proteinuria, we have to rule out, especially in the critically ill patient, we have to rule out rhabdomyolysis. How to estimate the severity of the proteinuria? We can collect 24 hours urine and estimate the level of the protein in that volume of the urine. But as an alternative to 24 hours urinary collection, we can rely upon the urinary protein creatinine ratio, which is the sensitivity of which is almost equal to 24 hours urinary protein estimation. But for urinary protein creatinine ratio, we have to collect early morning sample. We can grade the severity of the proteinuria if it is less than 30 A1, 30 to 300 A2, more than 300 milligrams per gram of creatinine, that is A3. In case of the nephrotic syndrome, the total protein should be more than 3.5 grams per day, along with hypoalbuminemia and hypercholesterolemia. What are the different tests to assess the tubular function? Basically, the function of tubules is to reabsorb the water electrolytes and maintains normal acid-base status. So by estimating urinary electrolyte concentration like sodium, potassium, chloride, magnesium, and phosphate, and by estimating glucose level in the urine, we can estimate the tubular function. We can diagnose renal tubular disorders like renal tubular acidosis, Barter's and Gentleman syndrome with the help of uh, by estimating the concentration of various electrolytes. By calculating urinary anion gap, we can diagnose renal tubular acidosis. By calculating transtubular potassium gradient or the potassium excretion in the urea, we can diagnose Gentleman and Barrett syndrome and can start treatment accordingly. The normal urine osmolality, if it is, should be more than 750. If it is more than 750, the concentrating capacity of the tubules is intact. If it is less than that, the tubular function has gone and it's not able to absorb the water. Diabetes insipidus can be diagnosed with the help of water deprivation test. Coming to urine analysis. Specific gravity to estimate the concentrating ability of the kidneys. The normal range is 1.003 to 1.03. If it is less than normal, that means the urine is dilute, the concentrating capacity of the tubules is gone. And the level of problem can be in case of hypothalamus, in case of CNS dysfunction, or if patients having raised intracranial pressure, the specific gravity is decreasing and urinary volume is increasing per hour if they are pouring 200 ml or 300 ml per hour, and the urinary specific gravity is less, that such patients will require emergency neurosurgical intervention or further evaluation. Color of the urine, if it is straw color, that is normal. Red means hemoglobinuria, blood in the urine. Cloudy means infection. The dipstick test is point of care test where we can detect glucose, protein, bilirubin, nitrate, leukocyte esterase. These are all various things we can see, or we can detect with the help of the dipstick. Nitrite means few enterobacteriaceae or a few gram-negative bacteria will convert nitrate to nitrate. So in case of UTI, the nitrate test and leukocyte esterase test will be positive. Glucose, if the blood glucose level cross the renal threshold, there will be glucosuria. This test is helpful, especially in the pregnancy population, to diagnose GDM. We can differentiate rhabdomyolysis with hemoglobinuria by looking at morphology of the RBC. If RBC is intact plus globin, that means rhabdomyolysis. If RBC is dysmorphed plus globin, that is hemoglobinuria. Normal RBC per high power field is 0 to 3, normal WBC is 0 to 5. Ketones, dipstick test, with the help of dipstick test, we can detect the ketones, but we only can detect acetone and acetoacetate, not beta hydroxybutyric acid. The urinary ketones level will be increased in case of DKA, starvation, and vomiting. If there is kidney dysfunction, the ketone excretion will get delayed. There will be delayed rise in the urinary concentration of the ketones. In such scenario, we have to rely upon the plasma concentration of the ketones. Coming to various casts, RBC cast we can see in case of glomerular nephritis and tubular damage, WBC cast in case of pyelonephritis, fatty cast in case of nephrotic syndrome, Hylian cast in case of glomerular diseases. Triphosphate cast will be coffin lid appearance. We can see in case of UTI and alkaline urine. Uric acid crystals we can see in case of the gout. There will the shape of the crystals will be needle shape. Oxide crystals are envelope shape. We can see in case of ethylene glycol poisoning and hyperoxaluria. Cystine crystals are hexagonal. We can see in case of cystinuria. Fractional excretion of sodium. This test is very much important to differentiate intrinsic versus prerenal cause of AKI, especially when CLD patients presented to us with AKI. If they are not on diuretics, we can rely upon this fractional excretion of sodium. If it is less than 1, that is prerenal issue. Such patients will benefit from IV albumin and IV fluids. If it is more than 2% intrinsic renal, such scenario, if if liver function is, if CLD, stage of CLD is advanced and even the kidney function is even the stage of kidney injury is also advanced, such patients may require liver kidney transplant. That means if a fractional excretion of sodium more than 2%, there is intrinsic renal damage. Such patients will not benefit from the fluid resuscitation or albumin. The kidney function will only get reversed by reversing the liver function, that is liver transplant. The formula for fractional excretion of sodium is 100 into urinary sodium into serum creatinine divided by serum sodium into urinary creatinine. If patient is on diuretics, we should not do fractional excretion of sodium. We have to stop the diuretics, and after 48 hours of the diuretic stoppage, we can recheck the fractional excretion of sodium. Other tests to differentiate prerenal versus intrinsic. If urinary spot sodium less than 20 millimoles per liter prerenal, fractional excretion of urea more than 30 prerenal, urinary osmolality more than 500 prerenal. If it is 300, it's mostly intrinsic problem, tubular dysfunction. That's all. Thank you.